And now we're going to look at renal. Renal I have in two parts for the slides. We have renal part 1, which is looking at acute and chronic renal failure, and then part 2, which will be the electrolyte section. The acute and chronic renal problems and the electrolyte imbalances together make up what is 5% of the test. So let's review. Cardiac is 36. Pulmonary was 14. Neuro, now I'm trying to remember myself. Neuro was 5 or 6. GI is 5. Renal is 5. And heme is 2%. So renal and electrolytes are 5% of the test. And that is covered under, let's keep everything in perspective so we understand how this all works, that is under clinical judgment. And then caring and ethical practices is the other 20%, 80% systems, 20% caring and ethical practices. So what are the functions? What are the functions of the kidney? What are the functions of the kidney? We looked at the functions of the liver, and now let's look at the functions of the kidney. The kidneys have 7 essential functions: the excretion of metabolic waste, urine formation, acid-base balance regulation, electrolyte regulation, and fluid regulation. Blood pressure regulation. Remember when we looked at the cardiac system, we talked about renin, angiotensin, aldosterone. And when we talked about that, remember the kidneys play a role in blood pressure regulation. And your kidneys also are always sensing your oxygen delivery. And when your oxygen delivery goes down, your kidneys say, oh, you must not have enough red cells. So your kidneys produce a hormone called erythropoietin. And erythropoietin goes to the bone marrow and says, hey, you bone marrow, you stem cells, I need some of you to become red cells because my patient, my body doesn't have enough oxygen delivery. And in fact, this may be a fallacy because the patient may have a low saturation because they're COPD. And that's why your COPDers have a higher red blood cell count, which is also why your COPDers are more likely to throw a PE because they're more likely to get a DVT because they have thick blood. They are hypercoagulable. But your kidneys play a role in your production of red cells, and that's why your renal failure patients are frequently anemic. And we have a drug for that, don't we? We put those patients on Epigen or EPO. And now that's a generic drug, so there's many different names for it. But it is basically a synthetic erythropoietin. So we're bypassing the kidneys and going straight to the bone marrow and telling your patient to make more red cells. So if those are the jobs of the kidneys, how do we assess renal function? We've got a lot of ways to assess renal function, don't we? We have blood tests. We can look at their BUN, their creatinine, their serum electrolytes, their H&H, their albumin, their osmolality. We can look at what came out and what was in what came out. How concentrated was their urine? We look at their UA, the renal clearance studies. We can look at x-rays like a KUB. And we can look at renal arteriograms to see how blood flow is going through the kidneys. We have other tests that we can do, like an IVP, CAT scan, ultrasound, and biopsies. A lot of tests for renal function and renal assessment. Unlike the abdomen, where do we have? Abdominal pain, bowel sounds. How good is that? How orange is my patient? But for renal, we've got a lot of good things that allow us to assess for renal function and dysfunction. Now, acute renal failure affects many body systems. Chronic renal failure affects every body system, doesn't it? When you think about these patients that come to you, most patients, unless you work in a dialysis unit or a renal unit, most of us, when we deliver care to the renal failure patient, they're not on our unit because of their chronic renal failure, but they brought their chronic renal failure with them when they came to our unit. So let's start with chronic renal failure, now more commonly referred to as chronic kidney disease. The reason why I left it as chronic renal failure for our discussion is in the new blueprint for the PCCN, which came out now about 2 years ago, they had not yet changed the name to chronic kidney disease. So I left it for our discussion as chronic renal failure. My guess is in the next update, which will probably be in about 3 years, they'll change the name to chronic kidney disease because that's what the literature has gone to now. But all of these are the same thing for our purposes as nurses at the bedside. They're a permanent, irreversible condition. The kidneys have stopped doing their job, which is remove the metabolic waste and the excretion of water from the blood. A lot of names for this, but most of us, to be honest, refer to it as chronic renal failure. What are the causes for our patients to have gotten chronic renal failure to begin with? Well, it could be a glomerular or a tubular or a vascular kidney disease. It could have been a urinary tract problem, an infection, anywhere in the body, but if it were in the kidneys to begin with, like a glomerulonephritis, they're even more likely to then move forward and get chronic kidney disease. A systemic vascular problem, or a metabolic problem, or a connective tissue problem. This is one of the reasons why you can see sarcoidosis or lupus lead to renal failure. The stages for renal failure, now here we're looking at chronic. We're going to get to acute in a few minutes. There's diminished renal reserve. You have a lot of reserve. Shoot, you could give up one of your kidneys today and go the rest of your life with a 50% drop in function and do just fine. And that's with a 50% drop. Now, let's say we kept both of our kidneys. By the time we are 80 years old, we will be down to about 6% function. And we may be doing okay. Most 80-year-olds do just fine. In fact, most 80-year-olds will tell you they pee too much, and they're taking care of those 7 essential functions. But at some point in these patients who have chronic renal failure, the decrease in reserve leads to a renal insufficiency. At some point, that insufficiency has gone on far enough that they no longer can take care of those 7 essential functions. And then that patient has chronic renal failure or end-stage renal disease. And this, as you know, affects everything in the body. Everything in the body. Think about all the medications that your patients are on who have chronic renal failure. None of those medications are for their kidneys. Those medications are for what the kidneys have done and the renal failure has done to the rest of the body. They're in a metabolic acidosis, aren't they? Because the kidneys are unable to excrete the hydrogen ion. All of these patients are on antihypertensive, aren't they? Now, did the hypertension cause the renal failure or the renal failure cause their hypertension? It really doesn't matter right now because they have both. These patients, when they scratch themselves, they bleed or bruise. They have a low H&H. They have ulcers in their mouth. They have ulcers in their stomach. Their whole GI tract can be filled with ulcerations because of their chronic metabolic acidosis. They're not very hungry. They have problems with constipation and diarrhea. Many of them have a flat affect. Have you ever noticed that in these patients? These patients will come into the emergency room now. I'll see them, and the potassium is 10. They're very acidotic. They're breathing very rapidly because they're so acidotic. And they're having PVCs. They're getting ready to go into VTAC and die. And I say to them, "Have you gone to when was the last time you went to dialysis?" And they say, "I was there about 3 weeks ago." "Why haven't you gone to dialysis? You could die." "I know. Whatever. Do what you got to do. I'm not feeling too good." And I look at them. I'm like, "Can you please get upset about this?" And they have that flat affect. And you say to yourself, all renal failure patients act alike. Now, we know that all patients are individuals. But you might say to yourself, well, then all renal failure patients are couch potatoes and don't care about themselves. And I would say back to you, it's the disease. If you show me a healthy, happy patient with chronic renal failure who's on dialysis, I will find you a helpful, supportive, loving family. Because no patient can go through this disease by themselves and come out the other end happy and healthy. Because the toxins poison their brain. The toxins give them an attitude of not caring about themselves. And if the family goes with that, they end up being alone. But the family who pushes and keeps the patient on track and supports them and helps them, and they know there's someone who's loving them and helping them, that patient will do well. And so we, as nurses caring for these patients, must pull that family and support group in because it takes more than a village to keep a renal failure patient happy and healthy and survive. And the neurological system takes a big hit. The pulmonary system, these patients are all breathing rapidly, aren't they? They have Kussmaul's breathing because they're in a respiratory acidosis, and they're trying to get rid of the acid that their kidneys can't get rid of, so they increase their respiratory rate. They're yawning all the time because they're high CO2. They are always tired. They're falling asleep. And with that flat affect, they look like they don't care when you're talking to them or telling them their story. And then the grandkids say, well, why should I go over there anymore anyway? Because grandma doesn't care what I'm talking about, and she falls asleep while I'm talking to her. And then their breath frequently smells like urine. Would you even want to go out in public if you had this disease? This is why these people shut themselves out of society. And then society helps to push them away because of their behavior. So pull these people in and keep them close and teach them and love them and get their families to do the same. It's the only way we'll keep them healthy. And then their skin, we've all taken care of those patients. You've seen their skin, that dry, flaky skin. You do not, I hate dry skin. You do not want to follow me when I'm caring for a patient with renal failure because I grease them up so much they almost slide out of the bed because their skin they're trying to get rid of those uremic toxins. And you know what their skin looks like? That's also what their pericardial sac looks like. And that's why many patients with renal failure, chronic renal failure, have pericarditis. And that's why you see more effusions in these patients and you hear more rubs in these patients as well. So chronic renal failure affects every body system. These patients are on up to as many as 13 different medications a day, and none of those medications are for their renal failure. We have no drugs for renal failure. We call the treatment for renal failure dialysis or transplant. So all those medications are for the other problems because this affects every body system. The treatments that we have for chronic renal failure are hemodialysis, where the blood leaves the patient's body, goes through a machine, comes back cleaned out with the toxins and the fluid removed. Peritoneal dialysis, where we actually use a catheter that we place in the patient's peritoneum below their belly. And on the test, it will be called a peritoneal dialysis catheter. For most of us in practice, it's called a tank-off, but that's the name of a company, so that name will not be on the exam. And here we run a dialysate into the patient's abdomen, and we use their peritoneum as the filter. And then we allow the toxins and the fluid to come out through that same tube. And then possibly a cure could be transplant. So let's look at acute renal failure. Acute renal failure is a sudden deterioration in renal function. It's usually associated with the loss of the kidney's ability to concentrate the urine, which leads to retention and accumulation of nitrogen waste products. So the BU and the creatinine go up and the urinary output goes down. And that's exactly the same thing you see in chronic renal failure. The difference here is not the renal failure part. These are both renal failures. The difference here is acute may have happened more suddenly, and the kidneys at this point are still potentially recoverable. Whereas when we determine clinically that they are no longer potentially recoverable, what do? We call it chronic renal failure. So now, what happens in acute renal failure is there has been a decrease in glomerular filtration rate, which leads to an interstitial inflammatory changes. Now, there's that word again, inflammation. With inflammation, you get vasodilation and capillary leak. Inflammation could lead to obstruction within the kidneys, and that would lead to a decrease in urinary output, even to no urinary output, so the patient can be oliguric or non-oliguric. Now, a patient could also have a large output failure, and that would be a non-oliguric. It doesn't happen as commonly, so please don't think because the patient is urinating, it's okay. When I see the terms written in someone's note, quantity sufficient, I say to them, what does that mean? Patient's peeing enough. Well, what's in their pee? Well, I don't know. Well, we got to look at it. Is it yellow? What's the specific gravity? Maybe get a UA on it, because a patient could have a high output failure where they do have sufficient urinary output, but the toxins aren't in it. Luckily for us, more commonly, it's oliguric or anuric. Now, the causes for acute renal failure. Look at the top and the bottom on this list. The top, severe hypotension. The bottom, severe hypertension. Both of these could lead to acute renal failure. Heart failure. How does heart failure lead to acute renal failure? Perfusion, cardiac output. Dehydration, nephrotoxic drugs. Now that could lead to permanent or chronic renal failure. And then any complication of infection anywhere in the body could lead to acute renal failure. Now, we label acute renal failure by its cause. All three of these that I'm going to show you are all potential causes, but they are all renal failure. In our very first lecture, in one of the very first slides, I said to you, cardiac output equals heart rate times stroke volume. And stroke volume is determined by preload, afterload, and contractility. In our pulmonary discussion, I said ventilation, perfusion, diffusion. You could have the patient could present with respiratory distress, and the problem could be in any one of those three places. A patient could present to you with an inadequate cardiac output, and we then need to say, is it a heart rate problem, or is it a preload, afterload, or contractility problem? And now we're discussing renal. You did realize this class was cumulative. I'm going to keep bringing up things I've already said. And if you don't say you remember hearing it, I will start over. So in renal, there is three major causes for acute renal failure, recognizing that all of these patients will present with low urinary output, high BUN and creatinine. But the cause, and the reason why we want to identify the cause, is that then helps us focus on where our treatments should be focusing on first. Like if it is a preload problem for the heart, we look at giving them Lasix or volume. If it's an afterload problem, we look at giving them a vasodilator or a vasoconstrictor. So, acute renal failure. If it's a pre-renal cause of the acute renal failure, it's usually a perfusion problem, dehydration, ischemia, hypoperfusion. If it's a post-renal problem, it's something below the kidneys. You know your anatomy. We've got the kidneys, the ureters, the bladder, and the urethra. So something is below the kidneys. If you put a Foley in someone and put a clamp on it and don't let them urinate for 2 weeks, you would have a post-renal problem. Now, no one's going to find that diagnosis because we would never do that to a patient. But it could be an obstruction somewhere in the renal anatomy, urethra, the bladder, or trauma to the kidney itself. Could be a trauma to the, not to the kidney, to the bladder or the drainage system. Trauma to the kidney would be a renal problem. So pre-renal, post-renal, or renal. And renal is the problem is in the kidney themselves, somewhere in the kidneys. But all three of these causes are acute renal failure. They are different causes for acute renal failure. Now, I'll be honest with you. The majority of the patients who we see clinically who go into acute renal failure after they're already with us, it is a pre-renal cause. And it's usually from dehydration, ischemia, or hypoperfusion. The patient that was a code that was recovered with CPR, but the code was long. Their kidneys took a hit. They could present to you in about a week in renal failure. Patients who have a kidney problem. Now, post-renal is the least common and the easiest to diagnose. May not be easy to treat, but it's easy to diagnose. Occasionally, we will have a patient who goes into acute renal failure and we don't know the cause. Please remember, the majority of the time, it is pre-renal. But when we don't know for sure, and we're thinking, is it renal or pre-renal, something you can use for assessment to help you differentiate between these two is some blood work. One of the jobs of the kidney, as we talked about in hypertensive crisis. Remember we talked about hypertensive crisis, you could have pressure-induced natriuresis because one of the jobs of the kidneys is to retain sodium. So we can use that to our advantage knowing that and look at the patient's urinary sodium. If it is a renal cause, the kidneys truly are to blame, they will have a higher than normal, higher than 20, urinary sodium level. That means their kidneys are not capable of retaining the sodium. If their kidneys are still sort of working, but right now kind of owie, their sodium will be normal in their urine, and that would be a pre-renal cause. We look at their BUN and the creatinine. If it is a renal cause or etiology, their BUN and their creatinine would both be going up. And if they're both going up, the ratio would stay the same. You've seen those patients who have an elevation in their BUN of 50, and a creatinine of 1.2. They have an elevation in their BUN, but not an elevated creatinine. And then we say it's a non-renal cause, because if it were renal causing the BUN to go up, the creatinine would also be going up. Then we might try giving the patient fluids or a diuretic to see if that works. It might work and cause the patient to increase their urinary output if it's a pre-renal cause. If it truly is the kidneys that are to blame, giving them fluid or giving them diuretics won't work because the kidneys are not working. And the cause then for the acute renal failure could be renal. Patients can lose up to 95% of their function if it happens slowly and insidiously and still take care of those 7 essential functions of the kidneys. In acute renal failure, when they drop by 50% that quickly, they're likely to have symptoms. And the symptoms will be very similar to the symptoms that we see in chronic renal failure. The phases for acute renal failure, something has happened. And remember, it's more commonly pre-renal, so it's usually a blood pressure or a volume problem. When the kidneys start to become ischemic and there's a decrease in glomerular filtration rate, the patient's urinary output will go down, their BUN and creatinine will go up. Now, their BUN may go up well before their creatinine goes up, and in that phase, it's probably still treatable. This is when we typically work for the patient and are trying to fix the problem. Then the patient starts to urinate. You and I say diuresis means more urine than they should have. What it means here, looking at acute renal failure phases, is they're starting to pee again. And then the kidneys will hopefully recover. Signs and symptoms, systemic response to renal failure, whether it's acute or chronic, blood pressure goes up, heart rate goes up, there's too much volume in the system, urinary output goes down. The brain starts being affected by the toxins. Pulmonary edema, you hear those crackles. The other signs and symptoms will depend on the patient, the type, whether it's pre-renal, renal, or post-renal, whether it's chronic or acute will be the other signs and symptoms. But everything really is very similar to chronic renal failure. So what is our job and our care priorities in a patient who has acute and or chronic renal failure? We, as nurses, want to monitor and assure hydration. Fluid challenges may be used in acute renal failure to see if we can kick the kidneys into business, and same with the diuretics. Monitor their fluid status, their daily weight, their I&O, their electrolytes, and their nutrition, because we may have difficulty in these patients. What kind of diet is a patient on? I would like you to type in at least one thing you can think of that a patient will be restricted for when we place them on a renal diet. Sodium, potassium, protein, excellent. Potassium, give me some more. You're missing protein and potassium. Potassium, sodium, protein. I'm only missing one that I want. Do we place these patients on any other types of restriction? And it may not be food. It could be the other part. Magnesium is true too, Gloria. Thank you. May not be food. Fluids. Thank you, Rebecca. Absolutely. Fluids. Yeah. You guys got it. I only told you to put in one to begin with, so you put in the big ones. But you got them all for me. So the renal diet, phosphorus too. Excellent, John. The renal diet is low protein, low fluids, low sodium. Those are the big ones, aren't they? And then we also look at the potassium, the magnesium, and the phosphorus. Now, here's a question. When we have the patient on a low phosphorus diet, what we might have them on is a higher calcium diet, because phosphorus is renally excreted. And we're going to talk about this in electrolytes in just a few minutes. When the phosphorus goes up, the calcium goes down. And that's why these patients are all getting some kind of phosphate-binding medicine, like Amphigel or Phosphobine, and then they're also being given some kind of calcium supplement, because when the phosphate goes up, their calcium goes down. And that's why many of these patients are getting Tums, because that Tums is calcium and bicarbonate. And bicarbonate they need because of their metabolic acidosis. Good job. So we look at our drug therapy, our diet therapy, which you just told me about. The drug therapy, we want to worry about some drugs are renally excreted, and they'll become toxic if the patient has renal insufficiency or failure, and that could be drugs like our digoxin. And then there are some drugs that are renally metabolized, and they will not work if the patient has renal insufficiency. So we may need to switch to a different drug. And we certainly need to worry about the doses of the drugs that are nephrotoxic. And renal replacement therapy and renal transplant may be our only other treatment options for these patients. And that brings us to our first polling question as we look at renal. 3 days after a cardiac arrest and a long code, a patient develops azotemia, oliguria, and electrolyte imbalance. The most probable cause of the acute renal failure is pre-renal, intrarenal, post-renal, and blunt trauma to the flank. I should say, or blunt trauma to the flank. Now, go ahead and pick your choice. You need some definitions from the stem of the question. Azotemia is elevation of the BUN. Oliguria, obviously, is a low urinary output. Anuria is no urinary output. And electrolyte imbalances you're obviously familiar with. So we need to pick from prerenal, intrarenal, or postrenal. Given the wording of the question and the patient had a cardiac arrest, you kind of could rule out blunt trauma to the flank, unless they did the CPR very inappropriately. Okay, we have our results. A was selected 64% of the time, and you would be right. A is the correct answer. Excellent. Prerenal because of perfusion. The cardiac arrest that was long code, and it was 3 days ago. It typically will take about 3 to 4 days for the poor perfusion and the subsequent inflammation to then lead to the blockage. And that may be when we see them out in our units, and it's a prerenal cause for the azotemia, oliguria, and electrolyte imbalance. Excellent. When we look at renal replacement therapies, we're looking at hemodialysis and peritoneal dialysis. And we talked about those with the chronic renal failure. And continuous renal replacement therapy is something that's used more commonly in the ICUs. And so we're not going to look at that specifically. You may hear about CVVH that is used in the ICU, and that stays there because the nurses there, it's not that we are not capable in the step-down units of doing this, but the machine is run by the nurse at the bedside, similar to the balloon pump or similar to the ventilator collaboratively with the respiratory therapist. And that's not something that we on the step-down units could do and manage safely when we have 3, 4, 5 other patients. And that's the major reason. So we looked at those briefly when I talked about chronic dialysis, but let's look at these more specifically. The goal of hemodialysis is to work for the kidneys. The access is either something permanent, maybe in their arm, or something temporary in a central line. The contraindications are that the patient cannot tolerate hemodynamically having that much blood outside their body at one time. We don't have access. The access that we have is infected or not working. The complications of hemodialysis, and not that you're going to be asked how to do hemodialysis on the test, but we may have the dialysis nurse come into our unit with their machine and then perform the dialysis. We're worried about electrolyte imbalances. We're worried about seizures. We're worried about clotting or bleeding. And we're worried about hypovolemia. And the care needs for us as the bedside nurse, caring for the patient who has acute renal failure or chronic renal failure who is currently being dialyzed. In peritoneal dialysis, the goal is the same. The access is through the catheter in their abdomen. There really are few contraindications, the major one being peritonitis. Complications, again, peritonitis, and the care needs are the same. And that brings us back to another polling question. While caring for the patient receiving peritoneal dialysis, the nurse notices that the drainage in the bag is yellow, cloudy with a slight pink tint. The appropriate management would be to A, stop draining, turn the patient on their left side, call the physician immediately. B, finish draining, send the bag to the lab for analysis. C, assess the insertion site, contact the physician while the draining is finishing. Or D, prepare for the next dialysate infusion, remembering to warm the fluid this time. And now some of you are saying, well, Carol didn't go over this. She told me what peritoneal dialysis was because I've never seen it before. But now the question is asking me how I take care of this patient. So you are all excellent, knowledgeable nurses. What comes out of that peritoneal dialysis catheter should look like urine. And what you're seeing come out is cloudy with a slight pink tint. So think about what you might be concerned about is happening. You're afraid this is infected. So we have a patient who's draining the dialysate, and I'm afraid they've got an infection. I need to go call somebody and tell them about what I'm seeing. But that's not what the question's asking you. The question's asking you is, what will you do? Will you stop the draining and turn the patient on their left side and then call? Will you finish the draining and then send bag to the lab for analysis? Assess the insertion site, contact the physician while the draining is finishing, or remember to warm the bag. So think through those. and think through what you would do, even if you've never seen peritoneal dialysis before. 35% of you have picked C, and you are correct. But I do see from this polling question, this is one of the ones where it's not a high majority. It is the majority, but it's not over 50% of you. This was a tough question. So let's work through this one a little bit more. We are afraid, I'm hoping we're all in agreement, that our fear in looking at the cloudy pink drainage is that our patient might be bleeding and that they might be infected. So those of you who picked A, stopping the draining would be a poor choice because we think there's pus in there. Let's let it come out. We do need to call the physician. Now, calling them immediately, what they're going to say is, what does the insertion site look like? And you'd say, I don't know. I just ran out of the room and called you. So, and turning them on the left side has nothing to do with anything. Turning a patient on their left side is something you might do for a pregnant woman whose blood pressure is going down because the baby's on the aorta. But in this case, turning them on their left side, if you want them to drain more quickly, you'd actually have them stand up. But if you stop the draining to begin with, turning them isn't going to make any difference as to whether the drainage comes out. Finish draining, yes. You will let it finish draining. 12% of you pick B. But send the bag to the lab. You know what? That's going to happen too. But that's not going to happen without an order. So that B is going to happen. But you have to pick between B and C as to what the most correct answer is. The appropriate management would be to assess the insertion site and contact the physician while the draining is finishing. And D, we do warm dialysate solution, and if we don't warm it, it's more uncomfortable for the patient, but it's not going to cause it to be cloudy or pink. So C is the correct answer. Let's go on to the next question. A chronic dialysis patient is admitted for pericardial effusion and drainage. Dialysis is scheduled for noon today. Remember I said some chronic dialysis patients do have pericarditis, which could lead to an effusion. So this patient's being admitted for the effusion, and we're going to do a pericardial centesis. So they got admitted. The dialysis is scheduled for noon today. But the computer system, now that we all have these wonderful computer systems, which I do love, I don't mean to be sarcastic about the computer systems, but they get to pick the time for the patient's medications. And the computer system has scheduled all of my patient's medications, my once-a-day morning meds, for 10 a.m. But the patient's dialysis is scheduled for noon. So what should the day shift nurse do? A, hold all the medications until after dialysis. B, determine which medications are affected by dialysis and change the medication schedule accordingly. C, give all medications as scheduled. Or D, send the medications with the patient to dialysis and tell the patient to take them mid-dialysis. Now, to be honest with you, I would pick E, call the dialysis nurse and ask them what to do. And some of you are laughing and saying, yep, that's what I do. But you know what? That's not one of your choices. So we have to pick from the choices that we are given in a multiple choice test question. So pick the choice that is the best answer for the day shift nurse for the patients whose medications are all scheduled for 10 a.m. when they're going to dialysis at noon. Excellent. The majority of you picked the correct answer, which is B. Determine which medications are affected by dialysis and change the medication schedule. And this question wouldn't even have been an issue if we had been able to schedule our own medication times, as we used to when we took our orders off. But I am thankful now that we have the computers for all the safety purposes, especially for those of you who have order input and med scheduling. But then we do have to reschedule. I know in our system we actually had to go in and they had to, once we realized this was going to be a problem, give us the ability to reschedule the medications, and not all the computer systems let you do that. But now they've realized nurses do need to have a say in this because it does depend on the patient. It really does. And that finishes our discussion of renal. Now, the other thing we have for renal is transplant. Transplant has been removed from the PCCN blueprint. It actually used to be under the heme immune section because there is a transplant certification test that none of us should be taking. We should be taking our progressive care test. Now, some of you who do work on step-down transplant units, I would say take your PCCN and then consider becoming certified in your subspecialty of transplantation. but transplant is a potential treatment for chronic renal failure, as all of you know, and we may be taking care of those patients. But the care of those patients and that knowledge is tested on the other certification exam. So we need to know that it is a possible treatment option for many of our patients, but not how it's done or all the drugs that these patients are taking. The second part of our discussion for renal is fluid and electrolyte imbalances. And I call electrolyte imbalances the chemical building blocks of the body. And what we're going to look at, because we really can't cover all of biochemistry in the 20 minutes that we have left, is we're going to look at together the big ones, and the ones that we as progressive care nurses it's important for us to know and be comfortable with in caring for our patients. And we might see questions on the PCCN exam. And that would include sodium, potassium, magnesium, and calcium. So let's start with sodium. Sodium is the major extracellular cation. Cation means it's positively charged. It has osmotic properties. It helps with acid-base balance. It has a close relationship with water. Remember, water follows sodium. And sodium's job is to help with active and passive transport across the cell membrane and also intracellular metabolism. Now, you might be saying to yourself, Carol, this is a long session, and you have crammed a lot in this session. And I'm trying to listen, and you just told me we're going to talk about biochemistry for 20 minutes, and my eyes started to roll back in the back of my head. At the top of the slide, it says that sodium is the major positively charged ion. But the bottom of the slide says it helps with intracellular metabolism. And see, that's the ticket. I hope all of you have something in front of you to write on and something to write with. I'd like you all to write, just make a circle, a big enough circle that you can write inside of it, and that's a cell membrane. I would like for you to write inside that circle a little bitty Na with a plus by it. You have a small amount of sodium inside the cell. And outside the circle, I'd like you to draw a large Na. You have a large amount of sodium outside the cell. You see, it's when sodium goes into the cell that we get action potential. It's when sodium goes into the cell that the heart can depolarize. So sodium helps with active and passive transport across the cell membrane and with intracellular metabolism. And that's one of the major jobs of sodium. But it's primarily outside the cell. It's when it goes inside the cell that we get the EKG or the EEG. Now, why might your patient have a low sodium? The human body, I'm holding up a glass of water, the human body is 40 liters. The adult human body is 40 liters of fluid, 40 liters. Notice how we measure sodium. Sodium is not measured in grams or milligrams. It's measured in milliequivalents per liter. So we're looking at the amount of sodium in this human body, which is 40 liters of fluid. How much sodium is in this fluid per volume? Milliequivalents per volume. So why might your patient have a low sodium? There's only two reasons. The patient has a fluid excess or they have a sodium deficit. We have poured more water in this beaker and not equal amounts of sodium, or we have taken sodium off your patient without the right amount of water. And everything else that can cause low sodium in the blood comes down to fluid excess or sodium deficit. And what will we see when our patient has a low sodium? Neurologically, headache, fatigue, apathy, seizures, confusion, coma. Pulmonary, respiratory distress. Cardiovascular, orthostatic hypotension, decreased central venous pressure. GI, anorexia, decreased appetite, weight loss, nausea, vomiting, abdominal cramps, muscle weakness. What are we going to do for a low sodium? Give them sodium. But you can't give it too fast, or you could cause the opposite problem. We typically will do it orally or through parenteral IVs, and we usually will use, in our environment, we'll use normal saline or Ringer's lactate. In the emergency situations, they may use hypertonic saline, which comes as heavy as 3% that we typically use. Actually, it comes as heavy as 25%, but what's usually used in emergencies is 3%. Remember, normal is 0.9%. Why might your patient have a high serum sodium? There's only two causes. It could be a fluid deficit. We pulled water off this patient, but not equal amounts of fluid, or a sodium excess. They took salt in, but not equal amounts of water. What will we see clinically in the patient who has a high sodium content? Neurologically, restlessness, irritability, lethargy. Seizures is on both high sodium and low sodium, isn't it? Pulmonary, dyspnea. Because when the sodium is higher content, you can get more in, which could lead to increased respiratory rate and difficulty breathing, tachycardia, orthostatic hypotension, dehydration, flushed skin, decreased urinary output. Why? Because the patient, their osmolarity will go up, their hypothalamus will identify that, and it'll produce more it'll tell the posterior pituitary to produce more antidiuretic hormone. That's why when your sodium level is high, you don't pee as much, because you're trying to fix the problem. This is why bars give out popcorn and peanuts. Who knew that bartenders had biochemistry? Because if you take in a lot of salt, you're going to become more thirsty, and you're going to pee less, which will keep you at the bar drinking and spending money. That's why they're more than happy to give away salty foods. And musculoskeletal in a high sodium situation, the muscles will become weak to flaccid. Now, biochemistry is very easy, but it's also very dynamic because electrolytes, you know from your chemistry, the positives and the positives repel, the negatives and the negatives repel, and the positives and the negatives attract. So chloride is negatively charged, and sodium and chloride go together. So now that we've covered sodium, we've actually also covered chloride, because sodium and chloride always go in the same direction. Now, sodium is positively charged and predominantly outside the cell. Potassium is positively charged and predominantly inside the cell. So now on your little diagram, I want you to draw a big K inside the cell and a little k outside the cell, because potassium is primarily inside the cell. And you see that they're going to balance each other out. So if the sodium goes up, the potassium goes down. If the sodium goes down, the potassium goes up, because we only measure the amount of the electrolyte that's outside the cell. Now, if you were to give me 40 milligrams of Lasix and I were to pee a lot, I would lose both sodium and potassium. But you gave me a diuretic that caused that to happen. Typically, left to their own balancing act, sodium and potassium go in the opposite direction. Sodium and chloride always go in the same direction. Now, how will we treat a patient who has a high serum sodium? We need to figure out how this happened, and there's a million causes. But the problem right now is the patient is likely to seize because of their high extracellular sodium. We need to give them water, and a lot of it. We can determine how much water the patient needs by calculating a formula. There is a formula called the free deficit formula, the free water deficit formula. We take the patient's weight in kilograms. We multiply by their sodium minus 140 over 140. No one is going to ask you to memorize this formula for the test. I just want you to realize clinically where the orders come from. There's biochemistry behind all these orders. So, 70-kilogram patient, the lab just called you with that critical value of 160 and made you spell your name, and then you told somebody, and then they're going to plug it into this formula. The patient weighs 70 kilograms, sodium's 160. This patient needs 5.88 liters to even out their sodium and their water. Now, you probably won't hang 6 liters of D5W. If you're going to use D5 half, which is probably what you'll be ordered, they're going to order 12 liters of that. But they probably won't say 12 liters. They'll just give you an order for a solution at a certain rate. And they can't give all 12 liters at once because that would make the patient volume overloaded. And while we're diluting out their serum sodium, we're going to try to discover how they got to 160 to begin with. What about potassium? Potassium is one of the major inside-the-cell positive ions. It helps with cell balance and function. It maintains cell osmolarity, electrical neutrality, and conductivity. It helps with nerve impulses and cardiac contractility, acid-base balance, and normal kidney function. Why might your patient have a low potassium? Remember, sodium is related to too much water and too much sodium. Not enough water, not enough sodium will cause high or low sodium. Potassium is related to intake and output of potassium. So low potassium would be a decreased intake or an increased loss. And there's one other function that could cause a potassium level to change, and that's the pH of the patient. When the patient is alkalotic, notice you drew that little K outside the cell. Normal outside the cell potassium is 3.5 to 5.5. Normal inside the cell potassium is about 130 to 150. So when a patient has a high pH or their pH is above 7.45, draw a high pH or write alkalosis outside the cell. Now draw an arrow going inside the cell. So when the pH is high, the potassium will go into the cell, which will give you less potassium outside the cell, or a low potassium. Remember, we measure the amount outside the cell. What do we see when a patient has a low potassium? Neurologically, we're likely to see lethargy, to confusion, to depression. Cardiovascularly, decrease in blood pressure, dysrhythmias, cardiac arrest. GI, we're likely to see decreased appetite, nausea, vomiting, distension. GU, we're likely to see dilute urine, water loss, thirst. Musculoskeletal, we're likely to see weak, flaccid muscles to respiratory arrest. Respiratory arrest is put under musculoskeletal because it's the diaphragm. That's why pulmonary isn't listed there independently. What are we going to do for a low potassium? We're going to give the patient potassium. It's not hard. See, this is why we as nurses, we learned what to do for the bad numbers, but we didn't always know why what was happening because we never had biochemistry. That wasn't typically part of our education. I had organic and inorganic chemistry. The closest thing we had to biochemistry in nursing was typically nutrition. So we give them potassium, either orally or parenterally, but don't give it to them too fast, because if you give it to them too fast, they could become hyperkalemic, and that can cause death. Why might a patient have a high serum potassium? Here it could be excessive intake, decrease in loss, or acidosis. And acidosis causes potassium to leave the cell. And remember, you've got between 130 and 150 milliequivalents inside that cell of potassium. And that's why acidosis can be so dangerous. That's why your patients who come in renal failure have a high potassium. Because now you might say, well, Carol, they should have high everything because they're not peeing. But isn't their potassium the highest? Because they're also acidotic. What are we going to see clinically in a patient with a high potassium? Neurologically, numbness, tingling, low reflexes. Cardiovascularly, conduction disturbances up to ventricular fibrillation and asystole. GI, nausea, vomiting, diarrhea. GU, we're likely to see oliguria and anuria. Musculoskeletal, we're likely to see flaccid muscles, irritability. Now, these patients from a pulmonary perspective will be breathing very rapidly. And the reason for that is because they're trying to get rid of the acid. So by Kussmaul's respiration, they can get rid of the acid. And that's why also we see high potassiums in patients with DKA, because the acidosis of DKA is causing all that potassium to leave the cell. Remember, potassium and sodium typically go in the opposite direction. Because high potassium is one of the most dangerous things that can happen from an electrolyte imbalance in our patient population, we have a three-part system. We want to protect the patient from going into VFib. And that protection is part one. You may be asked to give the patient calcium IV push. It renders the myocardium less excitable. It really doesn't do too much for the potassium, but keeping the patient from going into VFib. The next thing we want to do is to shove the extra potassium back into the cell. And remember we said alkalosis causes potassium to go into the cell, and that's one of the reasons why we'll give the patient bicarbonate. Insulin, as you know, helps to pull glucose into the cell, but insulin also helps to pull potassium into the cell. So you may give the patient 5 to 10 units of IV insulin. But what will that do to your patient's blood sugar? It'll make it go down. So you may actually walk into this room with 3 syringes, bicarbonate, insulin, and D50. And the D50 actually is to chase the hypoglycemia that you just caused by giving the patient insulin. Now, many of you have probably never heard of this next one, and you may never do it. I've been a nurse in adult acute care for 30 years, and I have never done this. It's primarily done in pediatrics, but it is something that could be done or might be seen on a certification exam. which is why I bring it up in the review class. And that is giving the patient albuterol, either IV or by inhalation. Because albuterol, as all of you know, albuterol is a broncho-2 receptor stimulant, which causes bronchodilation. The beta-2 receptors, which are in the lungs, are also on your kidneys. On your pancreas. And so that then would lead to the more production of insulin. But the reason why we hardly ever do it in adults is because many of our adults are diabetics. And if we're giving them the insulin IV, we don't need the pancreas to do it. And we can't trust their pancreases anyway. But please do remember for the test that IV or inhaled nebulized albuterol might be a treatment for a high potassium, to move the potassium into the cell. And the third treatment is to get the potassium out of the body. We can do this preferably with diuretics and a Foley, if you haven't taken all your Foleys out already, or K-exolate. And more commonly it's done with K-exolate. And the K-exolate has to come out the other end. Vomiting does not count. The K-exolate binds to the potassium, and the sorbitol helps to cause that lovely diarrhea for us to get the potassium out of the body. And remember, with any electrolyte that is elevated, we might use dialysis to bring it down. So, calcium, possibly. Shove the potassium back into the cell with bicarb, D50, and insulin, and remove the potassium from the patient's body.
Calcium and magnesium. Let's finish these up. Calcium is very different than potassium and sodium. Calcium is carried in your body in three ways, or actually primarily two, bound and unbound. The unbound calcium, also known as ionized calcium, is the functional electrolyte. The other half is basically bound to protein or something else in the body. When you get a total calcium, they're giving you both. If you get an ionized, that has to go in a different colored tube and has to go on ice. If you get an ionized, you're actually measuring the amount of functional calcium. But what if you get a total and they wanted an ionized, or they want to look at it later? You can actually take the total and plug it into this formula if you also have the albumin, and what you're doing is pulling out the amount of calcium that's bound to albumin. What's the job of calcium? It has many physiologic and metabolic processes. It helps with nerve impulse transmission, cardiac muscle contractility, plays an important role in the action potential in the pacemaker of the heart. Calcium is factor 4. It's one of your clotting factors. It helps with teeth and bones and smooth muscle contraction and vasodynamics. Now, your calcium is regulated very differently. Remember that sodium is regulated primarily by the amount of water and the amount of sodium. Potassium is regulated by intake, output, and pH. Calcium, you store calcium, and it's regulated by your bones, your intestines, and your kidneys. Your parathyroid gland is always evaluating your calcium level. And when it drops, it produces parathyroid hormone. If you have enough vitamin D, you will produce this hormone. Then it goes to your gut and it says, hey, is there any calcium in there? Carol, have any milk with that turkey sandwich you had for lunch? And if so, we'll pull some from the gut. If I didn't have milk with my lunch and there wasn't much calcium in that cheese, it's going to go to my bones and say, hey, bones, since you store calcium, give me some. And it's going to go to my kidneys and turn off the release of calcium. And then my calcium level will start to go up. When my calcium level gets above normal, my thyroid gland produces a hormone called calcitonin, which goes to my bones and says, stop it, don't release any more calcium, and goes to my kidneys and flicks the switch to excrete calcium again. Calcium is also affected by pH. When the pH goes up with alkalosis, calcium comes into the cell. When the pH goes down with acidosis, calcium comes out of the cell. Calcium's relationships are with phosphate and magnesium. Calcium and phosphate always go in the opposite direction, and calcium and magnesium typically go in the same direction. Why might your patient have a low calcium? Excessive loss, inadequate intake, decreased ionized calcium. Now that could be you gave your patient a lot of packed red blood cells. In packed red blood cells, there's a preservative called citrate, and calcium loves citrate. I'm not talking 1 unit today, 1 unit next Friday, 1 unit next week. I'm talking about that trauma patient or cardiac surgery patient or a patient getting volume resuscitated who gets 4 or 5 units in a short period of time. those patients should probably also be given calcium. Their total calcium will stay normal, but their ionized calcium will drop. And then again, since calcium comes from your gut or your bones, it could be the patient is not able to release them. And again, when the pH goes up, calcium goes into the cell. What are we going to see in a patient who has a low calcium? Tingling, seizures, dysrhythmias, cardiac arrest. Remember, it's a clotting factor, bruising, bleeding. Laryngeal spasm, bronchospasm, increased peristalsis, nausea, vomiting, and diarrhea. If they're losing their calcium from their bones and they've lost a lot, they may even have fractures. We can test. There are 2 signs to look for low calcium. The first one, you can tap the patient on their forehead, on their temporal, and you're stimulating the 7th cranial nerve, which is the facial nerve, and their face will twitch on that side. Trousseau sign, put some type of tourniquet, a blood pressure cuff works great, blow it up above the systolic pressure, make the arm a little ischemic, and you make the ulnar nerve ischemic, and the hand will begin to twitch and have tetany. What do we do for low calcium? Give them calcium, orally or parenterally, but that may not be enough. They might have a low calcium because they have a high phosphate. Then you need to give them the phosphate binding drug. They might have a low calcium because they have a low magnesium, and you have to treat the magnesium before you can treat the calcium. And they also have to have vitamin D. And monitor this all very carefully because you don't want to flip them the other direction too fast because high calcium can kill too. Why might a patient have a high calcium? Excessive intake, loss from the bones, increased mobilization from the bones, or acidosis. What are we going to see? Decreased reflexes, lethargy, coma, seizures, decreased activity, dysrhythmias, all the way to cardiac arrest, which is why you can't give the calcium too fast because their heart could stop. High calcium is one of the only electrolyte imbalances that actually causes constipation. Everything else causes nausea, vomiting, and diarrhea. They get kidney stones. We're seeing a lot of that with patients who've stopped using hormone replacement therapy because of the risk of the concern for breast cancer, and they're giving themselves massive amounts of calcium, and they're coming in with kidney stones because you excrete calcium through your kidneys. Musculoskeletal, muscle fatigue, hypotonia, bone pain. Calcium's relationships are with magnesium and phosphate. What are we going to do for high calcium? Volume expansion, loop diuretics. Now, you're not going to use steroids as a major treatment, but it is on the list. Give a drug that helps them start excreting calcium and stop stealing from their bones, and treat the underlying cause. And lastly, magnesium. It's essential for the production of energy. It plays a role in the sodium-potassium ATPase pump, cell membrane stability. Magnesium is a vasodilator, and it influences neurotransmitter release. Why might a patient have a low magnesium, excessive loss, decreased intake, impaired absorption, and alkalosis? What are we going to see? Agitation, depression, confusion, dysrhythmias, hypertension. Magnesium is a vasodilator. If you don't have enough magnesium, you will be vasoconstricted. GI, nausea and vomiting, musculoskeletal, cramps, spastic muscles, and tetany. What do we do for low magnesium? Give them magnesium, but not too fast. You can cause hypotension. Why might your patient have a high magnesium? Excessive intake, renal insufficiency, and a drop in pH. What are we going to see? Lethargy, tacoma, dysrhythmias, hypotension because it's a vasodilator, respiratory depression, apnea, muscle fatigue, hypotonia, fractures. Magnesium's relationship is with calcium, and they typically go in the opposite direction. What do we do for a high magnesium? Give them volume. That'll help dilute it. Diuretics. Decrease the intake. The magnesium intake is usually not from foods. It's usually from a laxative, because laxatives are very high in magnesium. You could use insulin and glucose, treat the acidosis, so bicarbonate, and again, dialysis. And we have one question that we can do, and then we'll finish up. A chronic dialysis patient missed 3 dialysis treatments. Admission laboratory tests report calcium 7.1, potassium 6.5. EKG monitor shows tall T waves and occasionally PVCs. While preparing for dialysis, the nurse would anticipate A, administering oral ammonium hydroxide and hanging a lidocaine infusion at 2 milligrams per minute, connecting the patient to an external pacemaker and administering 10 units of regular insulin IV push, preparing for arterial line and central line insertion, yeah, right, or D, administering 1 amp of sodium bicarb and recording 12 lead EKG. So this is looking at which one of those electrolyte imbalances is the most important. Is it that calcium or that potassium? From the electrolyte and from the signs and symptoms, which one do you need to do for this patient? Excellent. So the correct answer is D, administer 1 amp of sodium bicarb. Now, do all patients with high potassium need bicarb? Not necessarily, and not even if they're acidotic. But this patient is having cardiac implications because they're having occasional PVCs. If it were calcium and phosphate, that might be the answer for A, but or B. But this is showing the high potassium is causing PVCs, not heart blocks. So we would use the bicarbonate for the acidosis, which would help to move the potassium into the cell. And we're getting a 12 lead just because they had cardiac. Excellent.